speak about the global guidelines for chronic limb-threatening ischemia. It's a great pleasure and honor to be here with you today. And these guidelines were published this year, and I had the honor to be part of the writing committee. And in these guidelines are the result of the joint work of three world societies of vascular surgery: the European Society, the Society for Vascular Surgery, and the World Federation of Vascular Societies. The target population of this guideline were CLTI in adult patients, defined as patients with peripheral arterial occlusive disease and ischemic rest pain, or foot ulcer in diabetic patients or not diabetic patients, or associated with gangrene. The primary goal of these guidelines were to improve the quality of care for all patients with CLTI, as well as for those at risk for CLTI. And the second goal, to identify care research priorities in needs of further basic translational, clinical, and health service investigation to advance those aims. The guidelines contain 13 chapters. And before to start to read this chapter, I think that it's important to start with some new terms that you can see in this paper regarding the role of ABM, the role of glass, the role of limb-based patency, the plan, the TAP, different words that were introduced from the writing committee in this paper for the first time. I don't think it's important to stress the first and second chapter, but I think that we can start with the third one regarding diagnosis. In this chapter, the working group reported that it's very important in patients with clinical suspicion of CLTI to measure ankle pressure, ABI, and Doppler. And after that, we can define the pressure, TBI, and Doppler waveform. After the definition of the presence of peripheral arterial occlusive disease, it's very important to define the stage of limb severity according with the Wi-Fi classification that was reported in 2014 in the Journal of Vascular Surgery. And with this classification, you know that we can grade the wound quality, the ischemia quality, and we can define even the foot infection. And we can grade in 4 different grades between 0 and 3, all these 3 variables. When we put together these 3 variables, we can define the risk of major amputation in these patients that could be very low, moderate in the height, and then we can stage the Wi-Fi classification between stage 1 to stage 4. After the definition of the Wi-Fi quality of the limb, we need to define how it is possible to define the morphology and the extension of arterial disease, and then we need to complete the evaluation with duplex ultrasound or, in some center, CTA of MRI. After this evaluation, we can define exactly how it's possible to guarantee inline flow to the foot in these patients, and then we have to define exactly the preferred target arterial pathway. According with this approach, we can define the global limb anatomic staging system. This is a glass classification, is a new classification, clinical oriented, very close to the syntax used for coronary artery disease. Is based on defining the target arterial path in each individual patient by high quality imaging and required selection of a preferred infrapopliteal artery. The TAP is generally selected on the basis of the least diseased coronary artery, providing runoff to the foot, because the successful revascularization in CLTI is nearly always required restoration of pulsatile inline flow to the foot. The global limb anatomical glass classified the femoral-popliteal and infrapopliteal disease in 4 different grades, And we defined even the infrapopliteal pedal descriptor that you can see on the right side in 3 different grades. If you combine the femoral-popliteal and the infrapopliteal lesion, you can have the grade of glass, because the grade of glass come from 1 to 3, and you can see in this slide that we can combine a femoral-popliteal grade with infrapopliteal grade in a different subgroup of patients, and the glass stage 1 to 3 correlate with technical complexity of revascularization and then with technical success. And we can see in the next slide that stage 1 have a technical failure less than 10%, stage 3 technical failure more than 20%, and 1 year limb-based patency more than 70% in stage 1 and less than 50% in stage 3. After this evaluation, we can start with the strategy of the revascularization, and then we can start with the plan concept that is a new concept, very important in our clinical practice for the decision making. This plan is based on patient's risk estimation according to the risk of mortality after 2 years and according to the perioperative mortality, limb staging according with the Y5 classification and limb severity ischemia and anatomic pattern of the disease. With this plan approach, we can define if it's correct to go in endovascular or surgical treatment in these patients, and this guideline underline that it's very important, don't use always the endovascular first approach or surgical first approach, but we need to evaluate according to different variables. In some patients we can use endo, in some patients we can use surgical approach, because the success of the initial vascular intervention is of importance in CLTI, and that endovascular failure, like open failure, carry consequences. We think that it's important to conclude about the revascularization, that in patients with average risk patients we can use endo or surgical approach according with the anatomic complexity, according with limb severity. In patients with high risk, but in these patients we need always to use endo as a first line. We can use only surgical approach when endo have a high risk of technical failure. We think, according with the chapter 7 and 8, that we don't have any role about interventional non-revascularization treatment of pharmacotherapy or any type of gene therapy or cell therapy in patients with CLTI. The chapter number 9 underline that we have 5 major indications for major amputation, and that in major amputation we have a high percentage of perioperative mortality and a low percentage of ambulation in these patients. That we need, I think it's very important this point, this recommendation, we need to involve a multidisciplinary rehabilitation team from the time a decision to amputate has been made until successful completion of rehabilitation has been achieved. The chapter number 12 underlined the role of a center of excellence in the treatment of patients with critical limb-threatening ischemia to decrease the risk of amputation. The center of excellence is a virtual or physical location with a team of highly skilled experts who are often involved in research and innovation to advance their field. Regarding the center of excellence, we need different essential skills that you can see on the right side, 9 essential skills that are important for the center of excellence. And in the center of excellence, we need a multidisciplinary team of specialists, protocol-driven care, outcome monitoring and reporting, method of improvement, and educational research. With this approach, we think, according with the group of the writing group of these guidelines, these global vascular guidelines, that if you put together the Wi-Fi classification, the glass classification, the plan approach, and the multidisciplinary approach for this patient, we can improve absolutely the percent of patients with food salvage and the patients that can make capacity to move to ambulate with the food in our clinical practice. Then we can increase significantly the possibility to help our patients with chronic limb threatening ischemia. Thank you very much for your kind attention.